Today, I want to talk a little bit about various memory disorders, and I will talk about a few of the most commonly diagnosed memory disorders, also called dementias. And I will talk a bit about the early diagnosis, especially I will talk about biomarkers, so different tools that we have to identify cognitive disorders, hopefully early, and I will introduce you some of the scientifically known evidence in that regard. I'll talk a little bit about what we can do on a non-medication approach, especially cognitive training, and talk a little bit about neuroplasticity, and have some information about the existing FDA-approved medication for the treatment of dementia, as well as also touch on the new infusion therapies that are out there that are used for treating Alzheimer's disease, and maybe a look in the future as well. Um, all right, let's see. First of all, what are cognitive disorders? Well, cognitive disorders in general are just conditions that affect our memory, thinking, and behavior. Many times we think really about cognitive disorders when we think about short-term memory loss, forgetting things. Where did I park my car? Where are my keys? But there are so many other things that the brain does. We make complex decisions. We read. We write. We see things in space. We have to have good judgment. We have to monitor and balance our emotions, and all of those things are part of cognitive disorders often as well. And sometimes cognitive disorders, if they don't involve short-term memory issues, are actually missed for quite a while until finally someone really puts one and one together and sees a neurologist or a neuropsychologist to help identifying a condition. Of course, sometimes there's a whole spectrum, of course, from mild to moderate to severe. And then, of course, there are, for example, the most common condition is Alzheimer's disease, and it's our goal in our clinic in neurology to find out what you have and also see where you are on this spectrum of severity in there. And that's where this early detection really comes in. So it gives people answers, but also maybe there is opportunity to slow things down, improve quality of life, and plan for everyone, meaning the individual who is affected, as well as also family and caregivers, to answer questions and help along. And then, of course, with all of this growing knowledge, we are all together really waiting and hoping for cures. And unfortunately, there are no real cures for most of our cognitive disorders. But science is working on that, and things are really, really accelerating in the last couple of years what has been achieved. And I'm really looking forward to the next 5 to 10 years to hopefully see more breakthrough treatment options. So I have just a few slides about the general categories of dementias. Alzheimer's is the most common one, and Alzheimer's is a condition that is mostly marked by short-term memory problems. And short-term memory means that easy information that came to you that you just don't recall and that you need to be reminded of. And that can go on for quite a while. It might not even affect your quality of life. It might not affect your day-to-day activities as much as maybe a family member notice, a coworker might notice. But then forgetfulness, of course, progresses over time, and then it might get worse, and then it develops into this Alzheimer's condition that's easier to identify at that point. Many times, Alzheimer patients don't have other symptoms, such as behavioral abnormalities, sleep-related abnormalities, difficulties with judgments. They're just super forgetful. And it has been shown for many decades that there are harmful proteins that build up in the brain. And the two most important we know about is amyloid. What are just really kind of sticky clumps of abnormal buildup of protein around brain cells. And there are also these tau tangles. These are kind of twisted fibers that build up in brain cells. And in Alzheimer's, those neuropathological abnormalities build up, and there is a correlation between seeing those things and people having Alzheimer's dementia. There is a lot of back and forth and controversy, and I can answer probably questions about when there are coming up about how this amyloid really affects the brain and how much amyloid can cause Alzheimer's disease. And there's a lot of conversation in that. But altogether, there is a strong understanding that if you build up these proteins, you damage gradually brain cells, and that just can't be good. Another type of cognitive disorder is vascular dementia. That's sometimes kind of forgotten. And we see that often in our stroke center here at Health Partners, that folks have a small stroke and have a neurological deficit, and then they might have later another stroke and another stroke. And the stepwise approach of events really kind of knocks out one brain area after the other, and then you develop cognitive problems. And those really start more or less suddenly. So you're okay, and suddenly you have a problem. You might get a little better, and then you have another sudden change. And the stepwise decline is very typical for these circulation-related memory disorder, dementia. And we often talk about mini strokes too, because they are so tiny, these strokes, that they don't really cause a physical disability, but it causes this memory issue. And that is important to identify, because it may not progress as much or as accelerated as other dementias, such as Alzheimer's. And if we put you on the right treatment plan to avoid vascular events in the brain by seeing one of our stroke neurologists, for example, you can really slow things down with the right preventive approach. Hence, it's important to see someone and think about the diagnosis. Another extremely common cognitive disorder we see is Lewy body dementia. Lewy body dementia is a condition that is caused by Lewy bodies, and those are like abnormal buildup of protein inside of cells. And this protein is called alpha-synuclein, and it's a naturally occurring protein that is also similar to amyloid, happens to be in the brain. But if it builds up too much, then it makes these clumps, and these clumps hang out in cells, and that again causes memory problem. Interestingly, in that situation, though, is that in Lewy body dementia, you may have a little short-term memory problem, but the majority of people have other issues. So it affects, for example, your movement. So people get like Parkinson-like symptoms with like shaking, tremors, stiffness, shuffling gait, and slowness. And then their attention can vary up and down, and you sometimes are more awake, sometimes not paying attention enough, or you're kind of sleepy. People have hallucinations, and even at some point have dream enactments at night. That's a typical feature of this condition as well. As you can see, this is quite different from someone with Alzheimer's, where there's mostly just short-term memory issue. Folks with Lewy body have a lot going on. And again, a thorough neurological evaluation and appropriate testing can help give us an answer, hopefully early on. Another commonly seen dementia is the frontotemporal dementia. So frontotemporal dementia, as it suggests, affects the frontal part of the brain and the side part of the brain. And it's really interesting because these areas are mostly covering our day-to-day activities in regard to behavior, personality, language, and not so much actually memory. And those folks are noticed by family to just are like somewhat odd suddenly. So you do things that you traditionally wouldn't really do. They might be not wrong, but it just wouldn't be really you, really. You might be getting obsessed about certain things, or you do socially inappropriate stuff, or you're losing interest. And so your personality is kind of changing. Sometimes folks develop a profound language issue where it's hard to get the words out properly or to understand, while the rest of the brain is doing pretty well still. It would be called primary progressive aphasia, a subtype of this dementia. And many of the day-to-day habits can change. And so that, again, can be identified, hopefully, with a thorough evaluation, with a thorough conversation with patients, and important to make the right diagnosis here. Um, Now, dementia in general is on the rise. Worldwide, there is estimated that there are maybe even 55 million people that live with dementia as of 2020, according to the World Health Organization. And each year, 10 million are added to this group. And it's expected by 2030 to have 78 million, and in 2050, 139 million people that have some type of dementia. The majority of dementia patients are thought to live in low or middle income countries, and fast growing elderly population, especially in China and India and neighboring countries, are probably the majority growth we'll see on this occurrence of dementia. And in Minnesota, it's estimated by the Alzheimer Association that there are roughly like 100,000 residents have, for example, Alzheimer's disease in 2020, and it's suspected to be increasing dramatically to 120,000 by 2025. And it's shocking to see that the lifetime risk of Alzheimer's disease can be 1 to 5 to 1 to 10 in individuals, and they're 45 and older. So this is something that is happening, and we know about it, and we have to address it and urgently, and we all try from different angles. And there are many angles to address this question about the impact that Alzheimer has, not just on caregivers and patients, but also as an economical burden. So it's suspected and suggested by the Alzheimer Association Public Health area in Minnesota that unpaid caregivers, such as family member and friends that care for Alzheimer patients, statewide have a price tag of $5.2 billion. That's a lot of money, thinking about what we all do for free for our loved ones. And it's also felt that over time it will affect also, for example, the state Medicaid system. So this is not just affecting us at home with our family. It's a huge financial challenge, and that we have to answer. So that said, let me switch to our next topic in that regard, as we can already tell that dementia and Alzheimer and conditions are frequent and serious. And the first thing to talk about would be biomarkers. And you might have heard about biomarkers, and I just wanted to introduce that concept. And imagine like your body is like a car, and it has lots of little warning lights, and biomarkers are like these warning lights where suddenly a specific clue or signal in your body comes up, and that helps us to know something might be wrong even before you actually are sick. So it's like the little warning light that you have to change the oil, for example. And these biomarkers can be various things like protein or chemicals that are inside of your brain or in body fluids. And how does that help with dementia? And for example, in diseases like dementia, these changes that occur in cognitive disorders doesn't happen really overnight. It's really building up over time. So many times when you check for these biomarkers, we can diagnose things much, much earlier. Even potentially you might not actually have many symptoms, and catching these early signs means that we're able to start treatment sooner, which may help slow down disease or manage the symptoms better. And in short, overall biomarkers are likely to be really early warning signals that we need to take serious, and we and have a whole potpourri available that we have to pick from once we see a patient. So we don't do every test on everyone. That's why you have to see a experienced physician or neurologist to pick the right test. So, for example, in Alzheimer's disease, we often use spinal fluid markers, and spinal fluid is well. Imagine your brain is like a sponge soaked in water, and the water around the brain is called spinal fluid, so cerebral spinal fluid (CSF), and there are many important proteins that swimming around in that spinal fluid, including also amyloid. And in a healthy brain, there's a good of amyloid beta really freely swimming in the spinal fluid, and that's normal actually. But then when someone develops Alzheimer's disease, this amyloid starts to clumping together. It really just gets really sticky, and it makes these deposits, and then that's of course, like I earlier mentioned, causes disruption in your thinking process. But let's say if the amyloid is like it's clumping up and cluttered up in the brain, well, then it gets taken out of the spinal fluid. And so that means that these markers are actually pretty low in the spinal fluid because you're building up all these plaques in the brain. So we use this information to make the diagnosis or help us making a diagnosis. Let's talk about another biomarker in the spinal fluid that is often measured, and that's tau. So this is a little different than the amyloid that was like the soluble swimming around kind of protein. For tau, I guess the best way to explain it is imagine your brain is like a busy city, and this city has like neurons, like brain cells, and they have a support system similar to steel beams in the building, and that keeps everything in place. So the tau protein is like some of these steel beams that help to support and stabilize roads like microtubules, and that delivers really important supplies from nerve cell to nerve cell and throughout the neuron. And when the brain gets hurt, let's say from a concussion, some of these tau proteins leak out of these stabilizing structures, and then it will be measurable in the spinal fluid. And we call that an elevated tau. That means if you have more of that in the spinal fluid, then there's somewhere an injury. The brain actually sometimes start processing things and putting like extra chemicals attached to this tau, and then we, for example, call it phosphorylation. And when that happens, this tau becomes also sticky, makes clumps, and this is what these tangles are that you might have heard of or you read about. And these tangles really kind of block the brain's road and pathways, and again, the nerve cells cannot work really properly, and that's where this buildup also is potentially or likely a contributing factor to develop Alzheimer's disease. Now, as I mentioned, these things are measured in spinal fluid, and spinal fluid means you just have to get a spinal tap. That's a poke in the lower back where we take out some of that fluid. It's often done, every day done, it's fine, but it's somewhat inconvenient, and for all of us, it would be much easier if we can actually measure these things in blood. A blood test is much nicer than getting a spinal tap. So it has been for a long time very difficult to measure these markers like the tau markers or other things in blood. And but over the last few years, things have evolved, and we do have now these phosphorylated tau that can be measured, and actually it's pretty good, and it actually correlates with lots of these abnormal plaque buildup in the brain. So there are these markers that help us identify Alzheimer's disease now in bloodstream. There is another marker called neurofilament light chain. It's also a marker that is building up when someone has a brain disorder. So that's sometimes used. It's not too specific. I do like to point out that this tau markers that can be tested in blood should be really done in conjunction with a neurologist, and the results have to be processed properly. So this is not really a marker that you would check on anyone that's like 30 years old or 40 years old and just to check what's happening, because the results have a lot of consequences. So these markers have to be really, really carefully be used in collaboration with specialists, so that we can actually explain the results and also handle the results properly. Now, another kind of quote biomarker end quote is imaging studies. So this is not really a blood test or spinal fluid analysis. This is really a picture. And the most common one that we use is an MRI that you see here. On the left side, you see a normal brain, and on the right side, you see a brain of someone that has dementia. And an MRI is like really taking a super detailed picture of the brain with a high resolution, and we can analyze the size and the shape of the brain, and we can decide if it's normal or not normal, if you have had an injury, if there was maybe a stroke or a tumor. So we rule out a lot of other abnormalities that can cause memory loss. And like I mentioned earlier, the vascular dementia, the folks with the little mini strokes, you see that all on an MRI. So this is extremely helpful technology, and it's used every day. And you can see on the imaging studies pretty well the different areas of the brain, like the ventricles where the spinal fluid is, the cerebral cortex is where all the nerve cells are, and on the right side you see how everything is kind of shriveled. That's because things get smaller once the brain cells start dying off. Now, the MRI is like a snapshot, right? It's just a picture. But then there are other cool technologies that we have. And one of them is the PET scan, PET scan. And a PET scan is a nuclear medicine test where we give someone a radioactive marker, and this marker travels to the brain and will just linger around in that specific area. So, for example, this you see on the screen on the right side, a PET scan results of different conditions. And really how it works is we inject radioactive sugar, and then you go in a scanner, and the scanner will picks up where the sugar is traveling, and then you have to just stay in that scanner for a while, and you can find out, for example, in the top line in a healthy control, you see that the red part is all the sugar activity, and it should be technically everywhere in the brain. But if you, for example, if you go to Alzheimer's, that's the second from the bottom, you see that there is some red in the front, but you see like certain other areas, the temporal lobe, for example, has much less of this red, meaning less sugar activity. And so that gives us a clue that there is something going on with these cells. And so this requires a lot of experience from a radiologist to look at these colored pictures, but it's actually very, very helpful in making a diagnosis, or support our diagnosis at least. That said, we don't make the diagnosis of one disease or another by just looking at a scan. So that is not how it works. It's really a combination of all that information: physical exam, history and memory testing, lab tests, and these imaging studies. Now, last part of the imaging studies is to just throw out here is the amyloid PET. And that is also extremely helpful. Remember that I mentioned that amyloid is this protein that's super sticky and that builds up in the brain. Well, here we have actually a radioactive marker that can really travel to the amyloid area and attach to that. So here you see when you inject the amyloid in a patient with no Alzheimer's disease, well, there's not much of this redness going on because there's no amyloid buildup. But then here in this person who has Alzheimer's disease, apparently, you see these amyloid lighten up everywhere, especially in the frontotemporal area, and where short-term memory is located. And this gives us also a very, very good idea that someone has likely Alzheimer's disease. Now, you heard me talk about amyloid and tau is the main base of our understanding, for example, in Alzheimer's disease, why people have this condition and whatnot. There are other conditions that are analyzed and talked about, and there are hypotheses that maybe other things can also cause Alzheimer or at least contribute to Alzheimer. And this is a very long debate among specialists, leading almost to fistfights between the scientists. A few of those theories is that there is maybe somewhere a neuroinflammation going on that causes some of the support structures to collapse and not work properly anymore. There is the idea that maybe, like I said earlier, with the vascular dementia, that maybe there is not enough blood flow going through the areas where short-term memory, let's say in Alzheimer's, is located, is affected. There is a whole thing about brain insulin resistance, where people think that there is an impaired glucose metabolism. Sometimes actually Alzheimer is called a type 3 diabetes in some literature. And then, of course, people always think there's maybe somewhere a virus that causes that. To be honest, it's all like theories, and I really, really wish everyone luck to find the real cause for Alzheimer's disease in those theories. And I'm all ready to look through the science and jump on board. But for now, the amyloid theory is still the one that seems to be the most promising when it comes down to understanding what's happened on these imaging studies that I showed you, but also like targeting some treatment. So talk about treatment. So for many of these cognitive disorders, we try to encourage some form of a cognitive therapy, and that can be customized based on patients and individual situation. So a big concept here is neuroplasticity, and neuroplasticity is not easy to explain. But let's say someone has dementia, and some part of the brain, like a city, like I mentioned earlier, is damaged, and so some streets, some connections are just not working. Traffic lights are not connecting properly. But then in this neuroplasticity, you do some regular mental exercises, let's say puzzle or memory games. The brain can strengthen some of these existing roads or build new ones. And then you have like new connection made and the brain stays active. And it has been shown that when you do these mental exercises in these targeted important areas of the brain, where, for example, you have planning or decision making or short-term memory, these areas become more active and better connected. So keeping your brain active is a big deal. It's a real big deal. And I put down on the slide here a few of those training techniques, the memory strategies, spatial retrieval strategies, where things are, or computerized cognitive training. There's a lot of things that is often offered by occupational therapy and psychology to train folks to help to keep their brain active. I often say, like, you use it or you lose it in that regard. Now, there's a concept also of cognitive reserve. And so the cognitive reserve is felt to be like a brain resilience against damage. So meaning the more active your brain is all your life, potentially you are like affected differently when you develop cognitive problems. So some people say that higher educational activities in your lifetime may be a protective, have a protective aspect in regard to memory loss. People that had highly demanding mentally demanding occupations potentially would be also protected from some of the damage, although if once you get Alzheimer's, it will come, of course. But mostly I'm really excited about like engaging in these cognitive activities that I mentioned earlier. So, crossword puzzles, Sudoku, playing an instrument, learning a new skills is all super important to just stimulate your brain and keep it active. And it's not just the cognitive activity, but it's also the social interaction. Actually, social isolation is one of the big driving force in patients with dementia by accelerating the decline. You have to have a purpose in life. You have to get up and have a plan. And socially active folks that join some clubs, participating in community activities, going to discussion groups do better. And that's just often my main encouragement for all of our patients to just be active, right? Last but not least, another type of training that I have seen are just task specific training. And like I mentioned earlier, anyone with some type of dementia might have some type of a cognitive concern, and they're all not the same, of course. For example, like some patients have difficulties with facial recognition, and you can start training folks to recognize faces and photographs of names that people should be familiar with, and start training that. Same as with like object location memory and training folks either with a computer setting or in the room itself to find the objects that are used. So the medication management is really, really, really important, and figuring out with the patient as well as the caregiver the medication administration, how to deal with that. And I have often a question from family and caregivers: how do we do I help or don't help? And it depends really. I really encourage people that they take care of themselves. The patient takes care of themselves for example, all these tasks, but better safe than sorry that someone keeps an eye on it as well. So again, encouraging someone to be active, but then maybe you do have to have the caregiver keep an eye on medication or on the pill box altogether. Taking that all together, I think it's important to not to forget that cognitive training in dementia has a role. It's not for everyone, of course, but it is something that can be targeted to the deficiencies that the individual is affected by. And definitely talk to your doctor or your psychologist or your occupational therapist and see if they have some classes you can join. We have the brain gym in our Neurowell program, for example. As far as I know, they do some of these things, if I'm not mistaken. So we have resources on our website there as well. Let's switch gear and talk about medications. So there are medications that are known for a long time, for decades, in the symptomatic treatment of dementia, mostly Alzheimer's disease. Cholinesterase inhibitors, NMDA receptor antagonists, combinations of that, and then the newer therapies with infusion therapies where we use monoclonal antibodies that I'm gonna talk about that in a moment as well. The most common drugs we use is donepezil, rivastigmine, or galantamine, and these drugs are traveling to the brain and increase this neurotransmitter acetylcholine. It's really it's like a little molecule that travels between cells back and forth and sends information from one spot to the other. And if your brain has a decline of these um, nerve activities by increasing the level of this acetylcholine, you can improve some of these pathways. It really it overall it reduces the decline of these conditions. So that means it doesn't cure anything, but overall people have it stabilizes a lot of those cognitive activities. And moreover than that, more than that, it's not just short-term memory like I mentioned earlier. There's so many things you can forget. How to eat, how to get dressed, how to button a shirt, how to turn in bed. Many of those things actually get stabilized with these drugs as well. And we've seen sometimes that family and patient get really frustrated with the and feel that meds are not helping. I totally understand that. And then they stop the medication because there is no perceived improvement. But then, as it turns out, they suddenly have a decline of these activities, such as getting dressed, taking a shower, being confused. So I often encourage to continue medications if possible and tolerate it. The side effects, of course, are really important. Not super common, but they are, of course, the thing. And people get most commonly gastrointestinal problems, slow heartbeat, and muscle cramps that we look for. All of them are, of course, not acceptable, and we have to work with family and patient to see if they have the side effects or not, and if we have to switch medication. So these are like tablets that people take on a daily basis, similar to the memantine. This is also a drug that travels to the brain and also interact with nerve cells and neurotransmitters. And it's also actually known to slow down the Alzheimer's condition. And they've done research studies where folks were on the drug versus people that were not on the medication. And then after X amount of years, it turns out people that took the medication had less decline. That means not necessarily that things are improved that much, but it's just less decline. And that can be for many a benefit. We also combine this medication with the cholinesterase inhibitors. Side effect, dizziness, headache, confusion. I tell always people just see how you feel. And if you have a side effect, just let me know right away. And we either reduce the dosing or we just stop to see that it's all resolved. Most of the, if not all of the side effects are temporary. Few words about the immunotherapy. So these are these new therapies that you might all have heard about. Most commonly, Leqembi or lecanemab, and there's donanemab, and those are infusion therapies that are now designed for Alzheimer's disease. And so these immunotherapies are like how do you call it, like a cleanup crew. So it's they swim through the bloodstream, travel to the brain, and find these clumps that I earlier mentioned of these plaques of amyloid, and start attaching to them. And almost like a vacuum or a robot helper, they just connect with these amyloid plaques, and then slowly start dismantling them. And the body kind of then reabsorbs some of this protein buildup, and it slowly gets removed from the brain. It's a phenomenal idea, and it has been shown that amyloid really is reduced in the brain. Unfortunately, it's not the effect, the benefit is not overwhelming. And that's kind of a bummer. So we all hope that these drugs will be making a huge impact, that people get dramatically improvement and slow down things like right from the start, because you do really clear out the amyloid. It's very targeted and it's very specific compared to the other drugs, but it is a little disappointing. The studies have shown that certain subsets of memory tests are benefiting from this infusion therapy, but it is doesn't it, that it doesn't it's not free, right? So there are problems involved with this amyloid clearance once you clear it out. And most commonly we're concerned that sometimes patients develop an inflammation called amyloid related imaging abnormality, ARIA. These are like mini bleeds or mini swellings in the brain where really these antibodies attached to the protein and want to remove it. And as a consequence, there is inflammation building up. And that is being seen on MRIs, and it has led in some patients to true bleeding that are physically noticeable. In a majority of the time, there are microbleeds that the patient doesn't really realize they have. We see them on a scan. And so the risk and benefit has to be really looked at because you got to go to these infusions every 2 weeks or every 4 weeks. There's lots of monitoring. There's like now newer evidence that maybe the brain atrophy is accelerated in some of these drugs, and we don't know what that exactly means. So it's really, unfortunately, not this overwhelmingly convincing must-do treatment. So, meaning that if someone has Alzheimer's disease, you have to talk to your doctor and see if this is a choice, if you want to go that route, if you qualify. Are you a good candidate based on the risk and benefit? What's the time commitment? What does the insurance say? So it is, I wish it would be easier. And that's why I look forward to the future where things hopefully are easier and better working. We do offer these infusions at Health Partners as it is offered in other clinics. Again, a selective group of patients go that route, and we had pretty good success. Knock on wood, no real complication, luckily. So wrapping it up here, I want to just throw out my takeaways today. So remember, we talked about early detection, what is critical. There are biomarkers in the spinal fluid, in blood, there's neuroimaging. And the sooner we detect something, the quicker we can address it and figure out what's happening. I mentioned that dementia can be multifactorial. There are a bunch of different conditions that are either independently or potentially even overlapping. We talked a bit about the underlying mechanisms, amyloid tau, the vascular stuff, alternative theories. I showed you guys the current treatments that are FDA approved, the donepezil, memantine, and then of course gave you like a few insights on these new emerging infusion therapies. Oh yeah, and we talked about the plasticity. And altogether, I hope in the future that we understand better how inflammation, metabolic abnormality, vascular abnormalities might contribute, or better understand how they contribute to memory loss, dementia, Alzheimer's. Hopefully, we can find some personalized approach that is driven by biomarkers. So not everybody gets treated with the same big hammer that is just thrown over the head to like treat everybody the same, but actually customize the treatment based on what we learn on these biomarkers. And then figure out how these advanced therapies like the infusion can be more accessible for everyone and who is a good candidate, and sorting this out. And I hope that we can find out early detection. The earlier we detect, hopefully, the quicker we can treat it. And we all hope, and I know the Alzheimer Association hopes with their annual fundraisers and Alzheimer Walk, that hopefully that Alzheimer is not just a fatal disease, but maybe one day is just manageable, like we manage high blood pressure or diabetes. And you can see, and I'm hoping that official institution, insurances, the state, and the federal government see that a multidisciplinary approach, helping all of us handle dementia patients, and pharmacy, cognitive training, lifestyle interventions, that we get the support we need.